My name is Hertel. I am currently heading the neurosurgical department of Luxembourg, which is here in the Centre Hospitaliser, the national reference center.
I'm Jelke. I'm a resident in the neurosurgical department at the Centre Hospitaliser in Luxembourg.
I'm Alexandra Schweicher. I'm a nurse working here at Hertel since 2015.
We are treating patients from Luxembourg and also across borders from the neighboring countries in Belgium, France and also from Germany. In the recent 15 years we have established and built up quite a huge activity both in neuro-oncological and in neurofunctional surgery. Put this together because functional neurosurgery classically is seen as some kind of deep brain stimulation. We do a lot of these procedures, but it's classically not so closely related to tumor surgery. Nowadays, this comes more and more together. So we do more and more neurofunctional analysis, nTMS and something else, in the means of brain tumor surgery. And we could establish in the recent years quite a high level and very stable tumor surgery activity. And in the field of functional neurosurgery, we are working also cross borders in this hospital and in a hospital close by in Germany. So we are training also many patients with movement disorders, with pain, psychiatric disorders, and in tumor surgery we are dealing with all types of intraaxial and extraaxial tumors like gliomas, metastasis. We do awake surgery, we do a lot of skull-based procedures, and so it was possible in the last decade to establish a stable neuromonitoring activity thanks to many engaged people like specialized nurses, like very engaged residents, like speech therapists, which come also to the OR for awake surgery, ergotherapists, neuropsychologists. So we have a huge team working in this field. And so we absolutely wanted to integrate the TMS since many, many years. Now, more than 1.5 years, we have an increasing activity in this field. And now it's more or less, I would say, a standard in glioma surgery to do a perioperative mapping before surgery, after surgery.
At the beginning we were facing several challenges. In new navigation everything is about precision, and there are some requirements which are absolutely paramount. So first of all we have the creation of an accurate and exact head 3D model, and at the same time the differentiation is also very crucial.
Professor Hertel invited me to train for neuromonitoring, intraoperative neuromonitoring. I started with no experience in neuronavigation. It was challenging at the beginning because we have to start from zero, and so it was good to have support of the other team members.
We performed both also with the system and with the visor2 system. It went well, and it was quite accurate, which we could also reproduce during the surgery. There we also had to look first what are the gold standards, how do we have to evaluate the, certain speech errors, and how is it about the precision on the brain surface. And then we had to integrate also the entire system into the surgery planning software. There we spent many hours, but finally we managed, and yeah, as I already mentioned, quite successfully, which also we saw during reproducible results during direct electrical cortical stimulation.
We are working on both sides in the neurofunctional balance, so we are doing research in the functional area to preserve function of brain tumor patients during, before and after surgery, but also to increase the resection by analysis with special spectroscopic optical technology and things like that. And therefore we are really happy to have the TMS in the navigated form here, because we have also very high navigational activity. We have a high level of digitalization in the OR, in both in cranial and spinal neurosurgery. So TMS is an integral part of this. And then also we have, together with the rehabilitation center, with the colleagues from the pain clinic, with colleagues from neurology, psychiatry, we have now patients that have been treated with TMS. It should be an integrated part in modern brain tumor surgery, and it should be a complementary non-invasive technique in the field of functional neurosurgery. So both is important, because we have deep brain stimulation as an invasive part, but we have also TMS as a non-invasive part. Transcortical direct current stimulation will be another complementary technique that we will try to introduce, and this is, to my opinion, of utmost importance in modern neurosurgery.